So as all of us who are studying ketogenic diets and cancer do, I'll show you in a second. Our study from a few years ago was colloquially called the RECHARGE trial because it was a very stupid acronym, but I won't tell you what it was. So this is from RECHARGE to novel biomarkers, and hope to just update you on some of the stuff we're doing now. Collaborators are many, and I'm indebted to all of them, wonderful people. Richard Feynman's been my colleague and collaborator for many years. He's here. So we all aim to target the Warburg effect, and I think Colin described it very well. And this is the glucose and the glycolytic dependent phenotype. It's common to many aggressive cancers, and it's evidenced by a positive PET scan with 18 fluorine labeled FDG. FDG is fluorodeoxyglucose, so you can hear that glucose is in the molecule, right? And let's see, do we have any pointers here? No? Okay. Anyway, I think you can see what's going on, though. You can see the heart, because this is a rather fuzzy but still valuable PET scan that we obtained a long time ago. I still like it. And when a person is on a standard, rather high carbohydrate diet, well, insulin is secreted and drives glucose into the heart. So fluorodeoxyglucose is clearly visible in the heart. You can see the tip of the brain there. The liver is less well seen. Now, at the lowest portion of the liver, and on the other side, you can see the kidney collecting systems, because this is radioactive urine, thanks. All right, so there's the collecting system of the urine and the bladder. So the fluorodeoxyglucose is excreted into the urine, so you get that. But what you don't really want to see, but you do, are these multiple sites within the liver, which are glucose-avid metastases. And there's also another one in the lung. So this is a patient with metastatic colon cancer. In 2012, somehow we're all stuck in 2012 due to funding problems, but this was our study published at that time, as I say, called the RECHARGE trial, and it was a pilot study in 10 patients. Whoops. You give me two clickers and I get confused. All right, so the objectives were safety and feasibility of a 28-day ketogenic diet in 10 patients with advanced PET-positive cancer. We used an entry and an exit PET scan as a surrogate marker of efficacy. We were looking at the change in the FDG uptake between the two. And the patients were monitored for compliance and a systemic metabolic effect by getting a weekly fasting beta-hydroxybutyrate level. I'm not going to go over this in any detail, a little more information than I want, but you can see that, well, first of all, the patients were not selected, as you can see, by the tissue type, right? Because there are a whole bunch of different, there's breast cancer, ovarian, and so forth, a lot of different. The patients were selected by the metabolic phenotype, by the fact that they had a PET positive, and that they had a positive PET scan using fluorodeoxyglucose. That was the selection of the patients. The circled patient here was excluded from analysis. We weren't thinking, but you see that she had a biologically different tumor. She was surviving for 14 years. She had had no surgery on her breast cancer. She had had no chemo and no radiation therapy and was still alive. These other patients had multiple chemos failing, so we ended up having to exclude her from analysis. She was a biologically different patient. In any event, most of the patients, actually all the patients, experienced a certain amount of calorie deficit. This was not by intention. They did not, on average, they ate about 35% less calories. 5 patients, you can see in the blue, had stable disease or partial remission, and 4 had progressive disease. But there was no relationship between the calorie deficit. That was the same in both groups. They also lost about 4% of weight, but again, it was about the same in both groups. What did matter was the level of ketosis between the groups, and you can see that the level of ketosis in the stable disease partial remission group was about 3 times higher than in progressive disease. These are all pretty consistent. I mean, even the lowest one is around 10-fold over baseline. These 3, of course, are below, five-fold, about 4-fold and lower of baseline. This one, of course, looks like this patient should have responded. But that's actually part of the problem with cancer. Not everyone's going to respond, and we'll get to that in a little bit. still I thought was pretty promising overall. And the summary is that this was a prospectively designed and executed pilot study of a ketogenic diet as a cancer therapy. 10 patients completed it without unsafe adverse effects, and ketosis was observed. It correlated with the level of insulin inhibition. I didn't show you that slide, as you'd expect. And it also correlated with disease stability, which is consistent with the hypothesized effects on glucose-dependent cancers. So new work, which is what I really came to talk about, is we now are in the process of just starting a human trial of 65 patients with just diagnosed ER-positive breast cancer. The patients are randomized to two groups, one a ketogenic diet of 45 patients, and then versus a standard low-fat diet of 20 patients, a total of 65. The ketogenic diet is supplied by Natural Ketosis, which is a company in UK. These are vacuum-sealed meals. We get them in boxes of 28-day supply, so they have long shelf life, and we can ship it out to the patient right after their diagnosis to start. The standard diet is high in carbohydrate foods, which is supplied from a list we culled from a Fresh Direct menu, and patients selected so that they can come up to a high carbohydrate diet on that arm. And our question is, do biomarkers of cell proliferation, this biomarker Ki67 or Ki67, I guess depending on where you're from, versus cell death, which is a tunnel assay, whether these biomarkers change between biopsy and surgery, which is a period of usually around 3 weeks, between 2 and 4, depending on how long it takes to get the patient scheduled. Now, a biomarker study isn't exactly a therapy trial, but it's clearly related to one, because it provides information about the likely behavior of a therapy trial, right? And the question you might reasonably ask is 3 weeks or 2 to 4 weeks enough time to see a difference in a biomarker? And Goodwin and Dowling, I mentioned Goodwin before from Canada, studied metformin in a very comparable study. They did it a few times until they got up to about 500 subjects, and during the same time interval. And what they found was that there was a significant drop in Ki67 in the metformin-treated patients, but not in the control group. And I think everyone in this room will agree that metformin, while we don't really know quite how it works, we know it drops blood glucose and thereby it drops insulin, but we also know that a ketogenic diet is quite a bit better at doing that. And so if this worked for metformin, we at least have some reason to believe that we may be successful in showing a change in a 3-week trial using our diet. So, I came to show you a study of 65 patients, and so far we've managed to complete 1 patient. So, so I don't have a lot of data, but it's illustrative. So this is Ki67. This is the biomarker of proliferation. And you can see these brown stains in a lot of the cells. You can see a lot of other cells which don't have that stain. They're sort of grayish. And Susan Feinberg, our pathologist, has the laborious task of counting the numbers of cells and determining the percentage. So, and you have to do this in 4 high-powered fields, so it's very laborious. And then you get an average. So she found one of these high-powered fields had 44%, another 72, 73, and 79% that stained for Ki67. And this is on the biopsy. Now, in the tumor excision specimen, this is, 3 weeks later, you can see it looks like it's more, but I'm just, I deliberately picked that because I wanted you to see that it got worse. But it's still, she did all the counting, and it was, a little bit more. Hard to say if this is statistically significant from 4 high-powered field slides, but it was 51%, 79, 80, and 81 that stained in this follow-up, biopsy, from the actual tumor excision. So it certainly was no better. Now, when I actually tried to press Susan for what's the normal value of Ki67 in breast, she waffled, But I'll just say that by and large, the value is probably less than 10%. So these are both very abnormal values. This is a patient who didn't start off well and maybe got worse, but certainly didn't get better. This is the standard hematoxylin and eosin stain, the H&E, and the central area is the tumor with normal tissue around it, mostly. And this is 3 weeks later. It's a higher power field, but the important thing here is here you can see mitotic figures. This is a nuclear material separating in a mitosis, and it's only one slide, but it looks worse. And basically, there's a lot of mitosis if you look at a lot of other fields. So in 3 weeks, the tumor appears to have gotten worse, displaying mitotic figures, certainly not a good, possibly higher Ki-67, and also apoptosis relating actually to tumor growth, not to an improvement. And yet, patient 1 was randomized to the ketogenic diet. So this isn't very good, right? This is not what we were expecting anyway, but we have to take the data as it is. However, it turns out the patient was not in ketosis. The baseline shows ketone body sort of at the upper limits of normal. First week, if you want to call that marginal, borderline physiologic ketosis, you can, but you can see that really nothing happened. And the problem was our fault, it wasn't hers. She was supposed to be on a ketogenic diet, but turns out, I don't know what happened, but when we gave her the list from Fresh Direct, we included some foods which were not actually ketotic, and she jumped at them, and then she ate them. And entirely our fault. I forget, someone once told me that whenever you do a clinical trial, you have to expect that you're going to screw up the first 2 patients. Well, we've done it on the first one. But anyway, we're still on the second. So far we have 1.67 patients. The second patient is 2/3 of the way through the diet, so we're pretty close. But in any event, the other thing, so I just wanted to give you a flavor of what we're doing now in terms of the human trial. We're excited to be doing it. We're hoping to get more patients and to start doing it correctly, and that'll be good. And the other things we're doing is we're trying to develop some novel biomarkers. Ki-67 is not a novel biomarker, but it's of cell proliferation. It's been around, but it's not used routinely in clinical practice. It's too cumbersome to use, and the standardization is difficult. So it's not really truly standardized, as I say, not part of routine evaluation. And our team is working on developing a standardized method from large statistical samples, basically through automatic cell recognition of cell properties, counting these stains in a computerized fashion and being able to get a large representative number. So we're very excited about possibly bringing this to the clinic. Probably the most exciting thing that we're also doing is another novel biomarker, and Stephanie Mattingly is a colleague of ours who's working at University of Alberta in Canada. And she's, after 3 years of very hard work, she managed to actually label a ketone body with 18-fluorine. So this could be very exciting. We actually don't know what the use of 18-labeled fluoroketone body will do, but it is the 3rd major radio-labeled metabolic tracer after FDG and F18-labeled glutamine, and it could be for potential widespread use. Here's an example of an image that she obtained, and where it's going is just where you'd expect. So you see some in the brain. Okay, the eyes always light up. The bone and the marrow lights up very typically. But here's a tumor. This is actually an MCF7 tumor, which is an ER-positive tumor, one that we're studying as well in animal models. I'll tell you in a minute. This is bone uptake. Not as intense, but we're gonna be playing with that to determine how to manipulate the images, not the images, but the actual physiology. Just a black and white version of the same. From the side, this is not optimally shown for imaging. This is the sternum in front, but the heart is behind. So the heart also takes up. So this is just where you'd expect beta-hydroxybutyrate to go. It goes to heart, goes to brain, and it goes to tumor. So we believe this is the tracer. We believe this is actually an accurate analog of beta-hydroxybutyrate. So to be explored with this tracer, our first thing you have to do is find out the normative image findings under different dietary conditions, because you have to know actually how it behaves. And we're in the process of doing that. And because it goes to these areas, it goes to the brain, it goes to the heart, and goes to cancers, its distribution is similar to fluorodeoxyglucose. But perhaps it will be complementary in terms of the information for specific applications. We don't know yet until we try it out. And it may permit exploration of in vivo mechanisms of ketone bodies in cancer therapies, and perhaps identification in advance of susceptible patients. So, and the final thing I'd like to discuss briefly is the use of diet and drugs in mouse models. we're studying particularly two different mouse models with our collaborator EU CD1 nude mice and MCF, again, ER-positive breast cancer xenograft in 5 mice per group. We also have a spontaneous breast cancer tumor model, just to see what the difference is. All animal models have limitations, so we're going to try both. And the idea is to couple diet and rapamycin. Rapamycin, as Colin points out, well, you didn't mention rapamycin, but you mentioned the pathways. Rapamycin is a drug that was discovered on Easter Island, actually, and it inhibits mTOR. I was described as I'm older than most of you who know nothing about alphabet soup, but when I was growing up, there was something called alphabet soup, and that's what all these signaling molecules sound like. There's mTOR and AKT and this sort of thing. But anyway, mTOR is a growth molecule. It stimulates growth, and rapamycin inhibits mTOR. So it's been conceived of as an anti-cancer drug. It ought to be used as one. But sadly, like the PI3 kinase inhibitors that Dr. Cantley developed, it also causes counter-regulatory effects, and namely causes hyperglycemia. So we'd been planning to do this for a number of years. We're crushingly disappointed that Dr. Mukherjee and Dr. Cantley beat us to it, but we were in the process of doing it now, at least. And so we're looking at a spontaneous tumor mouse model and CD1 nudes and comparing a standard diet plus rapamycin versus a ketogenic diet and a ketogenic diet plus rapamycin. And we're looking at changes in tumor growth, cancer death markers, and overall survival. And we're obviously interested in testing whether a ketogenic diet synergizes with drug therapy to increase overall efficacy at lower drug doses and lower toxicities. So that's the basic idea. Just want to tell you very briefly about CD1. I stumbled on CD1 about 10 years ago when I was doing a study for some entirely other purpose. I picked it because I figured one day I'll eventually be doing animal research in cancer, and I looked at regular CD1s and put them on a ketogenic diet. And I was stunned to find out that, this is a mouse, it develops about 2 millimolar ketosis on a ketogenic diet. That's very unusual for a mouse. So this was terrific. I tried 2 different diet variants, 10% protein and 16% protein, for reasons too long to discuss in what time I have left. But basically, the amount of ketosis was the same at both, so we're still working on which one we're about to use. Animals have now been ordered. We hope to start the animal study to evaluate the dietary, plus drug regimen I just described. And so that'll be the 4th and final thing I discuss. Thank you very much for your attention.